Welcome back, everyone. We're going to talk next about Chapter 39, Hematological Disorders. The hematologic system is a huge organ that flows through the entire body and delivers nutrients and elements to the tissues. We're going to talk a little bit about the cells that make up the hematological system, and then conditions that can happen if there are variations in those cells. So each of the cellular components of the blood have different functions. We know the fluid component is blood plasma, and it helps move different cells through. But there are 5 cells that make up the blood lines in the blood, and they all have different functions. The erythrocytes are the red blood cells. The leukocytes are the white blood cells, and those consist of the lymphocytes, the granulocytes, and the monocytes. And then the 5th line are the thrombocytes, which are the platelets. So the erythrocytes are the red blood cells, and they are produced, their production is regulated by erythropoietin, and erythropoietin is found in both the bone marrow and in the kidneys. For red cell production, there needs to be several different elements that are available for the blood, including iron, B12, folic acids, and amino acids. These cells are round with a biconcave center. A term that you may hear or see written on labs are reticulocytes, and those are the youngest red blood cells. And a reticulocyte count indicates what the erythropoiesis rate is, and that is the turnover of new cells. For mature red cells, the life expectancy is anywhere from 90 to 120 days. We know that hemoglobin are the oxygen-carrying molecules of the RBC. To produce, they require iron, and then the iron combines with the hemoglobin to make an oxyhemoglobin, and that is the percentage of oxygen in the blood. For the erythrocytes, or the red cells, to develop, it's important that good nutrition is in place. So with red cells, there can be different structural variations depending on if it's fetal hemoglobin, which is hemoglobin F, or adult hemoglobin, which is hemoglobin A. There are also 2 variations that are common: hemoglobin A2, which is a mutation in your beta thalassemia, and we'll talk more about that, and then hemoglobin S, which is a sickle hemoglobin. Beta thalassemia is a blood disorder that decreases the production of red blood cells, and sickle cell is an inherited red cell disorder where the cells are shaped like a crescent moon, and they don't flow through the small vessels freely, and then they can clog the blood flow and cause. In the book on page 9, on page 739, there is table 39.1, which gives age-specific blood cell ranges. I encourage you to look at that. It is broken down into gestational age up through adulthood, but you will notice that the hemoglobin increases with gestational age, and then there is a physiological drop approximately 2 to 4 months after the baby is born. Any drops in these numbers are categorized based on the size of the red cell and their appearance, and we'll talk more about that. Also, the red blood cells have antigenic properties, telling us more about the classification of blood types, and we know that there's A, B, AB, O, and then what the RH factor is, and so there's different examples of that listed below. These distinctions become important if your child needed to have a blood transfusion. The next cells we're going to talk about are leukocytes, and these protect the body from foreign organisms or infection. They also help distribute antibodies. They are also known as the white cells, and they are made up of 5 different cells, which we will talk about. If your white cells are low, and this reference is talking about less than 500, your risk for infection is increased. If your white cells are on the high side, that could be massive infection or a leukemia. The white cells are divided into 2 categories: granulocytes, which includes your neutrophils, your eosinophils, and your basophils, and your agranulocytes, including your lymphocytes and your monocytes. The first ones that we are going to talk about are your granulocytes, and those make up about 40 to 70% of all of the white blood cells, and then they are divided into the neutrophils, basophils, and eosinophils, which all have different functions. The neutrophils' major function is phagocytosis, and that is fighting bacterial infections. The next is basophils, and those are related to tissue mast cells, and they are active in an allergic reaction where they release histamine and heparin. And the next under the granulocytes are the eosinophils, and they immediately release histamine and are used to destroy parasites. Also, these can be elevated in allergic type of reactions. The next category are your agranulocytes, and those consist of your lymphocytes and your monocytes, and they make up, the lymphocytes make up about 25 to 35% of the white blood cells, and the monocytes make up anywhere from 4 to 6% of the WBCs. They originate in the bone marrow and differentiate in the spleen and the liver, the thymus, and the lymph nodes. There are two types, the T cells, which are responsible for a cell-mediated response, and then the B cells, which are precursors of the humoral response. And last, the monocytes. They're relatively immature cells. In their mature phase, they're macrophages. Their primary function is phagocytosis, and they serve as backup for granulocytes. The last component that we're going to talk about are your platelet cells. They're the smallest cells in the blood. They're responsible for hemostasis and clot formation, so they come together if there's been a cut or an injury and adhere to the inner surface of the vessel and form a plug. They are essential for hemostasis and clot formation. The normal range is anywhere from 150,000 to 450,000. They are also associated with coagulation factors, and if there is a breakdown of platelets, then it's going to start a cascade of proteolytic enzymes in the clotting process. And other labs that are associated in the clotting process include prothrombin, thrombin, fibrinogen, and fibrin. I'm not for sure if I mentioned this in the beginning, but the life cycle of these cells are approximately 7 to 10 days. With all of these blood cells, hematological issues are classified based on the cell line that is affected, and we will talk more about those. Let's talk next about disorders of the red cells. If you have a patient that has these issues, it's important, as always, to get a good history, get a genetic history, ethnicity, and race, as you may need to know more for sickle cell concerns, family history, the child's history, where they were when their age when they were born, any environmental exposures, chronic illnesses, any issues with jaundice, unusual blood loss, easy bruising, bleeding, petechiae. You want to screen for their nutritional status, and you want to review their newborn screening. Sickle cell is the most common genetic disorder that's found on state-mandated screening programs. You also want to do a good physical exam. You're wanting to see what their growth patterns have been. You want to assess skin, look for any pallor or jaundice, look for petechiae, any retinal hemorrhage, any lymphadenopathy, joint pain, heart murmurs, enlargement of the spleen or the liver. So let's talk about some of the red cell disorders. The first one we're going to talk about is the red cells, anemia, and that's a reduction in circulating RBCs that can be from decreased production, abnormality, shortened life span of the red cell, or destruction. Nutritional deficiencies can definitely impact anemia, as is toxic ingestions. Not having enough red cells to carry oxygen can cause stress on the cardiac and the respiratory system. Most children can be asymptomatic. Be sure and look at table 39.3 on table 742. It's going to give more information on the shape of the RBC size and their shape. But when I look at table 39-3, that doesn't give us the information we need. I would recommend going to table 39.1 back on 739 and be sure and look more towards the ages that are at the mid part of the chart. It'll tell you what your hemoglobin is, what the MCV is, and give a little bit more information. But know that MCV, MCH, and MCHC tell about the size of the cells. If you have a low MCV, that means that the cell is small in size, meaning microscopic, and can be caused by low iron, lead poisoning, and your thalassemias. Higher MCVs means macroscopic, and that can be caused by meds, deficiencies in vitamin B12 and folate, and liver issues. Nutritional health deficiencies can be definitely impacted and can impact the red blood cells. Some more information about anemias. 90% of anemias in children are either iron deficiency, lead-related, infection-caused, or hemoglobinopathy. IDA, iron deficiency, and lead causes a decrease in the hemoglobin available for nutrient transport. This inadequate RBC production can be acquired or constitutional. On table 39-5 on page 749, there is a chart on differentiating different types of microcytic anemias based on the test compared to iron deficiency, thalassemia, or other anemias, and it'll tell you whether some of these tests will be higher. You can also have some hyperproliferative anemias where there is a decrease in erythrocyte production in the bone marrow. I believe we've talked that iron deficiency is one of the most common anemias found in children. The workup for an anemia is going to include hemoglobin and hematocrit screening. You're going to want to see what the RBC indices are and the morphologies. That's what we talked about previously with the MCV, MCH, etc. On page on page 747 in box 39.1, there is a table that talks more about the morphologic changes that are seen with anemias. It'll give you, such as if you had microcytes seen on your blood smear, that could be iron deficiency, thalassemia, or lead toxicity. If you had, let's see, blast that were seen on your peripheral smear, where that could be a leukemia. If you were seeing sickle cells, of course, that could be sickle cell. It could also be some different thalassemias. So this table will be beneficial if you were looking, on your blood indices that you see, okay, cells are too big, cells are too small. What might be possible diagnoses associated with that? Follow-up labs include iron, TIBC, ferritin, the RDW, and that FEP stands for free erythrocyte proference. I'm not familiar with using that in practice, but the book mentions it. With microcytic anemia, there can be a defect in the hemoglobin or globin synthesis. We know that there's decreased iron delivery to the bone marrow, and that can be caused by chronic inflammation, a condition called plumbism, which I had to Google it, which is lead poisoning, and then other iron deficiencies. There can also be globin chain synthesis defects, and that is thalassemia, and we will talk briefly on that later. Iron deficiency has a higher prevalence in Black and Hispanic children, with children that are obese, may be premature, or have low birth weight. There is a correlation with the child having a rapid growth spurt that may also then have some iron issues. You can have malabsorption of iron related to Crohn's disease, celiac disease, surgical procedures. There's universal screenings for hemoglobin at 12 months, and more often if there are risks seen. A minimum lab screening would be hemoglobin. A CBC provides information about all the cell lines. And in the ferritin, they mention here that it can be an acute phase reactant, and it can be a variable lab, and it can be increased or decreased based on the response to a stressor, such as fever or inflammation. So clinically, with iron deficiency, you may have a child that is irritable, restless. You may or may not heard of the term pica or pica, wanting to eat things that are non-nutritional. They may have anorexia, hemoglobin typically less than 8. There may be developmental delays or social or emotional disturbances. They also, another term is pagophagia, which is the desire to chew ice and eat ice. On exam, these kids may be very pale. They may have tachycardia, heart murmurs, signs of congestive heart failure. In severe anemia, it's important to do an occult blood test. The book gives some ranges based on what your hemoglobin is. Mild to moderate could be between 7 to 10 grams. Less than 7, consult hematology. Consider a hematology consult, and less than 4, consult a hematologist. Your RDW will be elevated, and it's the earliest marker for iron deficiency. With these kids, it's also important to assess for any lead poisoning. From a lab perspective for iron deficiency, the typical profile would be microcytic, hypochromic, meaning a pale red blood cell. Your MCV could be lower normal. Your RBC could be lower normal. Your RDW would be high, low ferritin, and a high TIBC. Differential diagnoses: lead poisoning, thalassemia, chronic diseases. If you decide to treat and there's no response in 1 month after further workup, this will require further workup, and you also need to be assessing for any blood loss. Management of IDA includes iron supplementation with iron, ferrous sulfate. You're going to want to reassess the hemoglobin hematocrit and iron studies in about 4 weeks. You want to assess if there's been a response to the iron and that the counts are going up. You would expect to see increase in the reticulocyte count in approximately 4 days, meaning there is more of a production of these cells. And you're going to want to continue iron supplements for at least 2 to 3 months to get them back to a baseline, and then continue to assess. Other pearls along the way: moms that exclusively breastfeed need to supplement their babies with iron at approximately 4 months, because mom's iron stores that the baby received would have been depleted. And it's important to encourage the mom to avoid whole milk until after 12 months. Some of the complications with managing iron deficiency are adherence. If you have little ones with sustained low hemoglobin, hypotension, signs of congestive heart failure, or other blood dyscrasias, of course you're going to refer those. Education is very important, and reviewing foods that are high in iron-rich nutritional counts. We talked about supplementation for breastfed moms, avoiding cow's milk. Goat's milk doesn't have adequate iron and folic acid, and avoid giving iron with milk. Also, it's important to give iron with vitamin C, as that helps increase the absorption of the iron, and to educate your parents that stools may be black after their child has been taking the iron. And then, of course, keeping medications away from children. All right, let's talk next about thalassemias. Thalassemias are hypochromic anemia that is hereditary. It's associated with a decreased synthesis of a polypeptide chain, usually is seen after 3 to 6 months. It's important to get a family history for anemia, miscarriage, jaundice, gallstones, and splenomegaly. There are two different types of thalassemias, alpha thalassemias and beta thalassemias. The first is the alpha, and it has several variants. It's a gene deletion on the alpha globin. One type is a homozygous hemoglobin, and that is associated with hydrops fetalis, which is a condition incompatible with life. The other one is homozygous hemoglobin H, which you can have some microcytic homochromic appearing cells, may be seen with hemolytic anemia, enlarged liver and spleen, and mild jaundice. These patients require occasional transfusion due to being in a hemolytic or aplastic anemic crisis. The next is beta thalassemia, and these can be confused with iron deficiency, and you differentiate by following the iron and ferritin levels. Giving iron to these kids will not help the hemoglobin and may cause excessive iron, resulting in iron overload. Cell-wise, they are mild hyperchromic microcytic anemia. Hemoglobin levels may be 2 to 3 grams below normal. As we talked about, monitor for iron accumulation. With the thalassemias, there are beta thalassemia intermediate and major. Major is more severe, requiring more correction, transfusion, splenectomy, etc. But this will be managed with a pediatric hematologist. Macrocytic anemia. Let's talk about that next. That is a megablastic anemia, and that is where the size of the cells are larger, where with iron deficiency the size of the cell were smaller. And you can have oval macrocytes and also hypersegmented PMNs, which are polymorphinuclear leukocytes. In this type of anemia, they lack folic acid and or B12. It may be due to diet deficiency, or an intrinsic factor for absorption may be missing. It's important with these kids to assess what their milk intake is from, because powdered goat's milk or cow's milk, a strict vegetarian diet, or even tapeworm infestations can be a cause of macrocytic anemia. These kids may be irritable, have inadequate weight gain, and may have chronic diarrhea. With these anemias, you can have weakness, pallor, the beefy red smooth tongue, elevated MCVs, white count may be normal, platelets may be normal. Dietary supplementation is going to be needed once the cause of the issues has been discovered. You need correction of that underlying disorder. There's also a classification of anemias called normocytic anemia. So the red blood cell size is normal in appearance. These can occur in chronic illnesses, occasionally in B12 deficiencies, but also with those that have traumatic blood loss or are pregnant. They're not very common in children. The book discusses a condition called transient erythroblastemia of childhood, TEC. We're not going to go into much detail about that. It's a benign disorder that is seen with anemia and decreased production of erythropoiesis from the bone marrow. It frequently follows a viral infection, and so it's associated with temporary failure of the erythropoiesis system, which stimulates the bone marrow to produce all of the blood cell lines. It typically occurs in previously healthy children between 6 months and 3 years of age. On physical exam, these kids may have increased pallor, decreased energy, fatigue. They may have lethargy, abdominal pain, upper respiratory infections. Jaundice may occur. Hemoglobin can be as low as 2.4, very low retic count. MCV, white count, and platelets may be normal, or the platelets may be elevated. High serum iron levels, and hypoplasia if a bone marrow biopsy was completed. Some differential diagnoses to include would be congenital hypoplasia anemia, a condition called Diamond-Blackfan syndrome and iron deficiency. The management is self-limited, 1 to 2 months. There's no specific treatment. If the hemoglobin is significantly low, a transfusion may be required and may need to be referred to a hematologist. We are at about 25 minutes, so we're going to close out this part of chapter 39, and we'll come back for part 2 and finish off the rest of our blood issues.